Hello, my name is Cary Kogan, and I'm presenting today on behalf of myself and Professor Jeff Reed on the ICD-11 Better Data for Better Mental Health. The WHO has as part of its core constitutional responsibilities to develop and maintain international health classifications. And the member states of the WHO use these classifications as standards for the collection and reporting of health data. Member states also use the ICD to define their obligations to provide subsidized care to their populations. ICD was recently approved, the ICD-11 was recently approved by the World Health Assembly, which is the assembly of the ministers of health from all of the 192 member states. And this is actually the first major comprehensive revision of the ICD in almost 3 decades. It incorporates a variety of advances in research as well as progress that has been made in terms of information healthcare technology over the 30 years since the ICD-10 was published, and that includes mental health. Regarding mental health, in terms of mental health in a global context, we have to think about neuropsychiatric disorders, which account for over 12% of total disease burden. Mental and substance use disorders are actually responsible for over 184 million disability-adjusted life years worldwide. They're also the leading cause of disability in terms of the years of life lived with disability. We also know that there is a large gap between the number of people who are in need of care and those that actually receive care. And so if we look at the gap globally, it's somewhere between 32 to 78%, depending on the specific disorder. So one way to address this gap is to accurately identify the needs of individuals early on and have this information properly encoded in a system that allows us to have data at a systems level, country level, and at a global level. And this data can then be used to improve the mental health care that we have available. So the ICD-11 is a system that is of classification that covers all diseases and disorders, including mental health. And for each disease and disorder, there is a title and then a short definition. However, this is not adequate for clinical care in the context of mental health provision. And so there is a more expanded version called the ICD-11, Clinical Descriptions and Diagnostic Requirements, which is the specialist version used worldwide to diagnose mental disorders. And this was also revised in parallel. The aims for this revision were to provide WHO member states with a better tool to help reduce disease burden of mental disorders, as well as to provide health professionals with a better tool to identify people in need of mental health services, as well as to inform which treatments might be most effective at the point in which they're most likely to encounter opportunities for care. So the development of the ICD-11 in order to achieve these goals put a focus on clinical utility. That is because we know that health encounters are the source of aggregated health data, right? So when patients see their provider, that's an opportunity for actually gathering data on that individual. And then that data can be used for making health policy decisions at a variety of levels. And health classifications are really that interface between that encounter and the data that we have. So if the classification is too hard to use and doesn't really provide helpful information for the clinician, it won't be used, and therefore the data will suffer, which will ultimately affect health policy and decision making. So a main goal of the ICD-11 was to improve this clinical utility and to measure that improvement, ensure that it actually exists in the revision to improve mental health data. And so there are a variety of innovations that came about through the development of the ICD-11. And these innovations actually took really a lot of their approach from psychological science. And I'll just mention a few in my presentation today. So the first is the metastructure, or the overall categories that were included in the ICD-11 and how they were organized into groupings. And this was based on this organization was based on both surveys of psychiatrists and psychologists internationally, as well as specific multidimensional scaling experiments to actually make sure that there was an optimal fit between the metastructure and clinicians' mental representations of psychopathology. There was also expert input on revisions through standardized content forms that I'll mention in a moment. Also talk about how best evidence was incorporated about psychopathology to enhance personalized care, which really takes advantage of the new functionality of the ICD-11 coding platform, as well as both the vignette-based and clinic-based field studies that were used to evaluate whether the goals were achieved. So starting with the metastructure, the ICD-11 was organized differently because it had much more capacity to allow for more categories per grouping, unlike the ICD-10, which was limited by 10 divisions per level because of the way the system worked, the coding system worked. In this case, rather than enforcing disorders into common groupings, the developers of the ICD-11 CDR were able to actually have as many categories as is necessary. In this case, based on the evidence, the preference is to have a larger group of diagnostic blocks, which would allow it to have a flatter, more clinically intuitive hierarchy of disorders. And in the end, there are 17 diagnostic groupings, example, the mood disorders, and 2 separate related chapters that were introduced in ICD-11, sleep-wake disorders and conditions related to sexual health. Another innovation is the inclusion of content forms. So working groups of experts, international experts, were able to provide their information, best practice, best knowledge available on these different areas that were included in the ICD-11. These are different categories of information that are found in the ICD-11 for each disorder category. And you can see them here, essential features that I'll speak about in a moment, additional clinical features, boundaries between normality and pathology, course features, developmental presentations, including child, adolescent, and older adult, differences in terms of how disorders present cross-culturally, for example, idioms of distress and different symptoms, gender features, differences across the genders, and then how do you tell the difference between different disorders that may have similar features. So a big innovation here is the essential features concept, which was introduced into the ICD-11 to really give clinicians more guidance on how to make a diagnosis. They're similar to diagnostic criteria. However, these are the features of the disorder that should be present in every instance of the disorder, and they avoid algorithmic pseudo-precision, where you have to have a certain number of symptoms and that those symptoms have to be present for a very specific amount of time. We know that disorders do not present this way in reality, and this allows for flexible clinical judgment to be exercised by clinicians. The other type of innovation was really to capitalize on the availability of these technological advances in the coding platform to allow for more personalized diagnostic care. And this includes this idea of pre-coordination, which is there are all different combinations of codes that relate to the disorders that are included, and these are the specific diagnoses that are explicitly included in the classification that are then encoded with a specific code, with each digit representing a different aspect of that classification. So for example, here we have 6A23.00, acute and transient psychotic disorder. First episode, currently symptomatic. And this is explicitly included in the classification, where 6 refers to the chapter, mental disorders. The second and third digits, A2, refer to the grouping of schizophrenia and psychotic disorders. The fourth digit is the specific disorder of acute and transient psychotic disorder. And then the 2 digits after the decimal place refer to first episode, currently symptomatic. And these are pre-coordinated. So all of the possible combinations are there. They're explicitly there and can be used to make a diagnosis. There are also what are called post-coordinated codes, and these are additional codes that can be added or concatenated with the existing post-coordinated codes in the ICD-11. They're added to that initial diagnosis to add clinically relevant features that are more personalized. Post-coordinated codes can indicate things like the specific symptomatic or course presentations that are applicable only to certain diagnoses within a particular diagnostic grouping. For example, with melancholia is a feature that really applies only to depressive disorders or episodes within mood disorders, not all of the disorders within mood disorders. So a code can be added to indicate that that individual has, let's say, a recurrent depressive disorder, current episode severe without psychotic symptoms, with melancholia. There are also extension codes that are a variety of different features that can be added on to indicate, for example, the severity of a particular diagnosis. From none, mild, moderate to severe. And these can be added to pre-coordinated diagnoses. And what this allows for is actually a more of a dimensional classification. So we know that mental disorders are really better thought of as a variety of interacting and underlying dimensions rather than as discrete categories. So nature isn't cut at its joints. In reality, these dimensions interact, and by being able to implement a dimensional description of the presentation within the classification, this actually puts a much stronger focus on the current presentation. It's much more compatible with a recovery approach rather than labeling people as a type of person, like a depressed person, a person with schizophrenia. We know that these disorders can change over time, and dimensionality actually can be represented in the ICD codes, even though it's a categorical classification. So as an example of this dimensional classification, we can see that, for example, in ICD-10, there were a variety of subtypes of schizophrenia: paranoid, hebephrenic, catatonic, etc. These were removed because there was simply no validity to these disorders. Rather, now what we have is an ability to actually describe the current functioning of the individual in terms of symptom qualifiers. And these are post-coordinated codes that can actually describe the degree to which a person has positive symptoms, negative symptoms, depressive mood symptoms, manic mood symptoms, psychotic symptoms, and psychomotor symptoms, and cognitive symptoms. And so what this does is this system allows us to summarize specific problems that really can be targets of intervention. And so just to give you a brief view of what this looks like, you can see that in this case, the code for schizophrenia first episode currently symptomatic is this code here. And then there's this long string of post-coordinated codes that actually describe, for example, that this individual was found to have positive symptoms that were of moderate severity. And so we get a much more personalized kind of diagnosis. In terms of the content of the ICD-11, not only were these innovations included in terms of banking on psychological science for the client, but also in terms of evaluating whether the goals were achieved. And this was done through two different types of field trials. These were the field trials using internet-based, case-controlled, so vignette-based studies, as well as clinic-based studies. So in terms of the first type of field trials, using the Global Clinical Practice Network, which was a network of mental health professionals, 16,000 or more, and primary care professionals from more than 160 countries who agreed to participate in these field studies. And you can see the composition of the Global Clinical Practice Network, about 40% from Europe, from the Western Pacific region, and from the Americas. Approximately a third are psychologists. And these field studies allowed the developers to specifically look at changes that have been brought to the ICD-11. So in terms of, let's say, PTSD, you can see that we were able to look at the percent agreement that clinicians had in terms of the diagnosis based on the revised classification. And so there's a slight improvement in terms from ICD-11 to ICD-10. There's the introduction of complex PTSD into the ICD-11 that did not exist really in ICD-10. It was enduring personality change, and it demonstrates the improvement in reliability. And also there were areas that were less reliable than the ICD-10, and this allowed for the developers to actually make additional changes or revisions to the ICD-11 CDDR. And to test those, actually, in addition to the internet-based field trials, there were also clinic-based field studies that were done in a variety of settings. And you can see here the list of settings to evaluate the clinical utility and usability of the ICD-11 diagnostic requirements in naturalistic conditions. So really in the settings in which they're intended to be used. And to evaluate the reliability of those diagnoses that really account for the greatest proportion of disease burden and mental health service utilization. These studies actually used a joint reliability design where two clinicians were interviewing a patient simultaneously and then separately provided their diagnostic formulations and ratings of clinical utility of the ICD-11. And here's just an example of the CAPAs, which are a measure of diagnostic reliability, and these are for psychotic and mood disorders. And they're very good. The CAPAs are for diagnoses, obviously for some of the disorders, a little bit more challenging. For example, for acute and transient psychotic disorder, and for bipolar 2 disorder or lower, this is actually a function of the number of observations often. It's important to emphasize that, that there was no guidance. This was entirely a naturalistic study. So interviewers did what they normally do and in terms of their own practice. So this is really a way of measuring how the ICD-11 would perform in clinical settings. And you can also see here, if we compare the results of, let's say, the ICD-11 to the ICD-10 field trials, which admittedly were conducted differently, but you can see the comparison that for the most part, many of the areas of the ICD-11 are actually outperforming ICD-10, which tended to actually to overestimate the reliability of the classification. In terms of clinical utility again there was a specific measure that was designed for this for examining this aspect of the ICD-11, and these are the different kind of categories of clinical utility. And just to show, in the highest categories where clinicians are rating the ease of use, the goodness of fit, whether the guidelines are clear or understandable. And if you look at that, just the quite and extremely, the highest ratings. The ICD-11 has, quite a high degree of clinical utility as rated by those users in this study. So again, these are very positive ratings, in terms of ease of use, goodness of fit, and clarity and understandability. And these results are published in this article. And to conclude, so some of the implications and conclusions here. And I hope you'll take away from this presentation that there was the use of psychological science throughout the development of the ICD-11 clinical descriptions and diagnostic requirements, that this was a main goal of the ICD-11 revision was to improve and enhance clinical utility. And this was included in both the design of the structure, capitalizing on the innovations of the ICD-11 platform, to be able to implement these a more dimensional kind of personalized classification, and that these revisions were specifically assessed both in internet-based field trials to look at very specific revisions and then to make further revisions based on those data, and then following that to look at more naturalistic settings and to see how the ICD-11 operates within the context of clinical care in a most naturalistic way, and that ultimately the idea of enhancing clinical utility of the ICD-11 is to make sure that those health encounters actually serve as a basis for really transforming and translating the patient presentations into better mental health data in such a way that mental health data can then be used to make good policy for mental health care globally. Thank you very much.